Some weeks bring a bone-deep tiredness that a weekend of rest cannot fix. It is an exhaustion that persists regardless of the hours spent asleep. Consider a patient we'll call Marcus. While he is a fictional composite, his experience represents a specific clinical pattern frequently seen in Georgia. Marcus describes a constant state of hypervigilance. He experiences intrusive thoughts, emotional numbness, and somatic complaints, physical aches and pains that appear without a clear medical cause. The common societal response to this list of symptoms is to label it as workplace burnout or general stress. Misnaming this condition has consequences. Treating severe trauma as simple fatigue ensures the underlying cause remains unaddressed, leaving the individual to carry the burden without appropriate support. Following a burnout diagnosis, Marcus is often advised to take a vacation, improve his sleep hygiene, or dedicate more time to self-care. He follows these instructions, but the symptoms remain. The hypervigilance and numbness do not lift with a change in schedule. A weekend off cannot resolve a trauma response. Relying on these mismatched interventions allows the trauma to persist and can lead to further psychological harm. The actual mechanism at work is race-based traumatic stress. This is the cumulative psychological impact of racism-related stressors, including direct discrimination, microaggressions, and the weight of vicarious exposure through news and community events. Although a formal diagnosis must come from a licensed clinician, researchers identify a profound overlap between these symptoms and recognized trauma disorders. This comparison shows clinical overlap. Both traditional PTSD and race-based traumatic stress share core symptoms of hypervigilance and intrusive thoughts. Traditional PTSD is typically linked to a specific past traumatic event. Race-based traumatic stress is different because the stressor is ongoing, an environmental factor they cannot avoid. Living within an environment of unavoidable microtraumas alters the body's baseline state. For the person experiencing it, everyday existence becomes a continuous act of endurance. When patients seeking help encounter the cultural match problem, the clinical process breaks down. Friction arises when a clinician does not share or genuinely understand the client's cultural and environmental context. This creates a translation tax. The client spends their limited session time explaining and validating their own reality to the therapist, rather than doing clinical work. When therapy requires the patient to work to be believed, it stops being healing. This burden frequently causes clients to leave therapy and never return. Effective treatment requires trauma-informed care from a clinician who requires zero cultural translation, supported by community connection. Coping and healing counseling was built to provide this exact structure for patients in Georgia. The practice maintains a team of over 15 licensed therapists, including LCSWs, LPCs, and LMFTs. At CHC, cultural competence is a foundational staffing decision. The team is intentionally diverse to ensure that clinical work can begin immediately. Using 100% HIPAA-compliant telehealth, CHC provides coverage across all 159 Georgia counties. Access also depends on cost. Medicaid involves a $0 copay, and most commercial plans like Aetna, Cigna, and BCBS range between $10 and $40 per session. Individual treatment outcomes vary. However, removing financial barriers allows the client to focus on finding a clinician they can trust, which is the essential foundation for addressing trauma. The therapy room offers a rare opportunity to set the weight down without having to first prove how heavy it is.